Welcome back from your break. I'm really excited for this next speaker. This is Dr. Zaf Qasim. He is going to be talking about a subject that I know he's very passionate about. He's written a lot about it. He's talked a lot about it. And I think it's going to be a very exciting one. Zaf, what are you going to be talking about today?
Well, today I'm going to be breaking down the resuscitative thoracotomy, a really exciting, energizing procedure that a lot of people think about but might only do once or twice in their career in emergency medicine.
All right, take it away.
All right, thanks so much for having me. So really great to be here with the ResusX crew. I hope you've been enjoying the conference. So my name is Zaf Qasim. I work in the emergency department as well as the critical care units over at Penn in Philly. And you know, when I'm faced with a patient who is dying, I really want to think about what is killing my patient. And so I'm thinking about three major things, primarily hemorrhage in my trauma patient, but also thinking about things like hypoxia and an obstructive pathophysiology. And when I talk about obstruction, I really mean things like a tension, pneumothorax, or a cardiac tamponade that can really obstruct the circulation and cause our patient to arrest. So I'll approach this using the HOTTT algorithm. So HOTTT stands for hemorrhage control, oxygenation, thoracostomy, which I'll do bilaterally, transfusion, which is ideally done with blood, trauma ultrasound, and if the patient's condition dictates and the system allows, might proceed to a thoracotomy. So let's talk about briefly those first components because the basics really matter here. So hemorrhage control comes in many shapes and forms. There's a lot of cool stuff out there that you can utilize, like these hemostatic gauzes that you can pack wounds with. For the right injury, you can put tourniquets on, really safe and effective. And binders, like pelvic binders, are really important adjuncts to hemorrhage control in the right injury pattern as well. Oxygenation, remember to wear gloves, not like this person, but oxygenation is key not only with intubation, but you can use basic airway maneuvers like we talked about earlier in the conference as well. Thoracostomy, I'll do open thoracostomies or finger thoracostomies. And you know, in the heat of the moment, I won't bother to see really which side might be the cause of it. I'll open the chest bilaterally. So do a finger thoracostomy on both sides because you just won't know really which side might be affected. And think about where that space is. So when you have the arms up, you want to be aiming a lot higher than you think it is. So really count out your spaces. You want to be in the fourth or fifth intercostal space, anterior axillary line, which is usually a lot higher than people think. So really count out those spaces. Transfusion, thankfully, a lot of people have now moved away from crystalloid resuscitation. So if they're bleeding blood, give them back blood. And our trauma ultrasound can really help us define what might be going on, plus help us in an aspect later on, which I'll talk about. But if you're really stuck for time, I try and get two views, which is the pericardial view as well as the right upper quadrant. That lets me know if there's a major obstructive pathology or whether there's bleeding below the diaphragm. So now we've done all that, and now we come to that last T, thoracotomy. So I would say that well before you decide that in your department, especially if you're working in a community hospital, that you're going to be doing a thoracotomy when the right patient rolls up, you should have had a conversation about that with your peers. And those peers include your surgeons, your nurses, your anesthesiologists, and maybe even your transport team if you have to transfer these patients out to another facility after you do your damage control resuscitation. Because ultimately, regardless of how good you are at the procedure, this person will need to go to the operating room. And if they don't have that rapidly available, then there might not be much point in doing the procedure at all. So if you've decided that you can do this in your facility, you have to think about when am I going to pull the trigger and start this race. So there's a lot of guidelines that are out there. I'll just bring up two of them. One is from EAST, the Eastern Association for the Surgery of Trauma, that kind of looks more at an anatomical and pathophysiological approach to proceeding with a thoracotomy. So they strongly recommend doing it if the patient has had a penetrating thoracic injury and shows signs of life. Signs of life could be things like eye movements or any purposeful movements, things like that. And then conditionally recommend it when there's injuries in other parts or there might be blunt trauma as well. Western trauma, another big trauma society in the United States, takes more of a time-based approach depending on mechanism. So for blunt trauma, less than 10 minutes of CPR. For penetrating trauma, as long as it's not in the neck or the legs, then they recommend less than 15 minutes. If it is in those spaces, they say less than 5 minutes of CPR. But they also advocate its potential use if this person has refractory hemorrhagic shock. So you could utilize it in those states as well. But I'll go back to thinking of as an emergency physician trying to do this, think about some simple things you can do to decide whether it's actually going to be beneficial to open this patient's chest. And one of those things could be just your pericardial fast exam. So this group out of LA put out this paper a few years ago. They looked at putting a probe on a person's heart just before they open the chest, and they found that if there was no pericardial effusion and no cardiac activity, none of those patients survive. So you might use that as your determination whether you want to proceed or not. There's some unpublished data that should hopefully come out soon from our friends across the pond. This is from London's Air Ambulance. You may have heard of them. They do pretty active pre-hospital care, including thoracotomies in the pre-hospital setting. They looked at the electrical activity that was happening in the patient before they proceeded to thoracotomy and linked it to outcomes. And they found that as long as they had some sort of narrow complex rhythm on their monitor, those patients were much more likely to survive, and importantly, survive with neurologically good outcomes. So the later you leave it, as they deteriorate into this broad complex rhythm, and certainly in asystole, it's unlikely that they're going to survive or survive with any good neurologic outcomes. So you might decide that's your cutoff point to proceed. Once you've made the decision to go, keep things very, very simple. And that starts with the equipment, right? So most hospitals I've worked in just take the chest set from the operating room and bring it down to the emergency department and label that as the emergency thoracotomy set. And even our surgeons freak out a little bit when they open this up because there's so many instruments in there. So you really want to think about making that as simple as possible. And a lot of those things you can find in stuff you have around the emergency department anyway. You'll need some forceps, pickups. You can actually sterilize trauma shears, which, as long as they're good quality, can actually go through the sternum. Skin stapler is a good tool to have. We'll talk about that later in cardiac wounds. A couple of things that are more dedicated to the procedure are the Finichetto rib spreader retractor and a vascular clamp, which is an atraumatic clamp that usually doesn't lie around the emergency department, but you can make a pack like this through your sterile services and have it ready in the emergency department. Now, in North America, most people who do a thoracotomy will end up doing a left anterolateral approach. And I think if you're familiar with what you're seeing, I think this is a great approach. It's pretty fast. But if you're doing this maybe once in your career, I would really advocate as an emergency physician to do a clamshell approach. And there's a bunch of literature out there now that shows that the times to do this procedure are pretty similar. But look at the view you get. Instead of looking through a deep, dark hole, you're actually getting a broad view of the whole mediastinum, the lungs, everything you need to see to be able to fix what might be wrong. So how do you do this? Well, remember, in that HOTTT approach, we've already done bilateral thoracostomies, and really you're following those rib spaces and connecting those two holes across the sternum. And once you do that, you can make a very generous incision, deep incision. Remember, it's not cosmetic, going through the skin and soft tissue down to the musculature, using your trauma shears to go through the musculature and across the sternum. And you can then lift up the hood like a clamshell. And that gives you the exposure. So once you're in, you have a few priorities. Number one is to evacuate the pericardium and deliver the heart, because a small amount of fluid developing rapidly in that space is likely causing the obstructive pathophysiology. So pick up the pericardium if you can. Sometimes it's really tense and you won't be able to pick it up with forceps, so just make a nick in it. Stay in the midline away from the phrenic nerves, which are on either side of the pericardium. And I like to actually make an inverse T incision so that I can really open up the pericardium and deliver the heart. If there's any blood in there, immediately evacuate that, and then really look at the heart on both sides. Remember, it's a 3D structure. The injury might actually be posterior. Be a little bit careful that you don't lift up the heart too much. You don't want to obstruct the outflow tract, but find that hole. And once you find that hole, you have to decide, how am I going to fix it? And by fixing it, I really mean a temporary fix until this person can get up to the operating room. So our surgical colleagues will often say suturing is the ideal way to fix this, taking real great care to avoid going through a coronary artery if it's near a coronary artery. But I would say it's easier and faster to use a skin stapler to be able to approximate that wound, especially if you're addressing it in the ventricles, which are the structures that are going to be more anterior to you. Some people talk about putting a Foley in there, and by doing that, they actually put the Foley in and then inflate the Foley to kind of close up that wound. I'm not too fond on that. A lot of times, that small cavity, now you're taking up with the Foley balloon, and when you hand this off, say, hey, hold on to this, that person inevitably has a lot of adrenaline pumping, and they might pull too hard on that and make that small hole much bigger as they yank out that Foley. So avoid that, but if you do decide to do that, neat trick is put the blood transfusion tubing right onto the Foley and you can transfuse right into the heart. Cross-clamping the aorta is something you've probably always heard about, and you think, oh yeah, that should be simple to do. Actually, not so simple. So there is this ligament, the inferior pulmonary ligament, that you have to dissect, and the aorta itself, which will often be flat at this point, is encased in a fascial layer as well that you have to get through. So it's not as easy as it sounds. And if you're having difficulty, then guess what? There's probably at this time about 25 people who've shown up in the room looking to see what you're doing. And so grab one of them, tell them to suit up and put their hand along the posterior chest wall and press down on the vertebral column. And that can allow some temporary manual cross-clamping until the patient gets to a next stage of care or somebody else with more skill comes down to help you out. So an easy, quick way to temporarily occlude the aorta and allow that flow of blood back up into the heart and the lungs. Finally, think about what you need to do in terms of compressions. So compressions are often done, people think about it as closed chest. In this, you really want to think about using your hands anatomically associated around the heart. So you want to place the apex by your wrist, actually allow blood to fill the ventricles, and then squeeze it up out into the aorta. So think about your hand positioning. You don't want to be clapping like that. You want to be gently squeezing that blood out, but maintain that rate of about 100 a minute. Hopefully by then you've got some help. This patient has gotten ROSC. You can get them up to the operating room and hopefully get a good outcome. So I hope this has given you a good overview and broken down those steps of the resuscitative thoracotomy so that if in your system you can do this for the right patient, for the right indications, it becomes a little bit more simpler when the proverbial hits the fan. Thank you so much.